Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of summary of standard medical textbooks, that is nothing but standard medical notes. So today we'll discuss about a topic, last topic of vascular series. So that is chronic venous insufficiency and post-thrombotic syndrome, from definition to management. So before going to the topic, first remember that there is something called as chronic venous disease. Chronic just wait. Chronic venous disease. So this is an umbrella term which constitutes two things: chronic venous insufficiency and post-thrombotic syndrome. And also we can take in this varicose veins. Okay, but this does not mean that all varicose veins have chronic venous disease, but a chronic venous disease have varicose veins. So that you should remember. Now coming to the basic pathophysiology. Okay, first you know the anatomy which is given here in this, sorry, as you can see here. So basically there are two systems. So this is one vein. Okay, this is the deep fascia, and this is another vein, which I have explained this in the topic of deep venous thrombosis in detail. And these are some connecting veins. Okay, so these are superficial veins, and this is deep venous system, and these are called as perforators. Okay, so these deep veins are enclosed, they are within the calf muscles, like gastrocnemius and soleus. So the thing which happens is, when you walk, so there is contraction of these muscles. Okay, these muscles will contract, and these veins have walls. Okay, these veins have walls. So these valves ensure the unidirectional flow of blood from the legs to the heart. So when you walk, these muscles contract and the blood will flow upwards towards the heart. Okay, the direction of blood flow upwards, but there is gravity acting against this. So that is countered by this valvular mechanism which acts unidirectional. Okay, so what will happen when the blood goes up from the heart? So the blood which is there in the superficial veins will enter to the deep venous system through these perforator veins, and this cycle will continue. Blood will from here, it will come to here, and from here it is pumped to the heart, and the backward flow is limited by these unidirectional valves. That's why these calf muscles are known as peripheral heart. These are known as peripheral heart. Learned in anatomy always. Peripheral heart. Why? Because they pump blood. They pump blood towards the heart when you walk. But the problem arises when you don't walk. If the valves are faulty, if these perforators are faulty. So that is the problem which when it arises. Okay. Now you can see here. So this is a femoral vein. Okay, this is deep venous, and this is great saphenous vein. This great saphenous vein is a superficial vein. Okay, popliteal vein, and posterior tibial and deep veins of the anterior tibial vein. So all these are this is superficial part, and these are deep venous system part. So these are connected by perforators, as I said. So there are two perforators in the thigh. One is the Cockett's perforator, and one is the Boyd's perforator. In the thigh there are two perforators. There is one is Cockett perforators and Boyd's perforator. Whereas there is one perforator in the calf, that is Dodd's perforator. Cockett's perforator and Boyd's perforator in the thigh, and Dodd's perforator in the calf. Cockett's, Boyd's, Dodd's. So any problem in perforators also causes this venous insufficiency. Okay, moving forwards. So definition. What is the definition? Core definition: impaired venous return causing retrograde flow, stenosis or occlusion, leading to, this is the main root cause of this chronic venous insufficiency. So that retrograde flow will cause sustained venous hypertension in the limbs. Retrograde flow will cause sustained venous hypertension. So the disease is a spectrum. It ranges from asymptomatic cosmetic changes like telangiectasias, meaning small spider veins, to debilitating venous ulcers. Okay, one thing to remember here is you should differentiate it from post-thrombotic syndrome. While symptoms and signs of post-thrombotic syndrome resemble to that of chronic venous insufficiency, but when they occur, they are chronic venous insufficiency only, but they are because of deep venous thrombosis. What is the definition? So, symptomatic chronic venous insufficiency following a deep venous thrombosis. So what is the prevalence? Affects up to 50% of DVT patients. Severity 20 to 35%, meaning approximately 20 to 40% develop moderate to severe disease. Okay, what are the risk factors? Proximal deep venous thrombosis is a risk factor. Recurrent same side deep venous thrombosis is a risk factor, and body mass index more than 22 is also a risk factor. Then how you will identify whether this CVI is due to DVT or not? So there will be history of anticoagulancy. If you ask the patient, he will give a history of anticoagulancy. So that's how you differentiate. Now see here. So a healthy valve, what will happen? Blood will flow. Blood will flow from here to here, but it is unable to go back. Okay, but when the valves become incompetent, blood will flow, but followed by that it will go back again here, because there is a defect involved. There is a reflex. Okay, that is called as a reflex moving forwards. Now the pathophysiology, the failure of the pump. Which pump? The peripheral pump, the peripheral heart. The failure, the calf muscle pump. So how it acts? It requires a functional valves, number one, and plus a muscle contraction to push blood from soleal sinusoids. Soleus is a muscle. So to push the blood from against gravity. So it requires two things: valves and muscle contraction. So anything which impairs these two things will cause venous hypertension. Okay. So primary insult is either deep venous thrombosis, which causes obstruction, or valve incompetence, which causes reflux, and muscle pump failure due to immobility. That will cause venous hypertension and sustained retrograde flow. So at the tissue level, what will happen? There will be microvascular damage, capillary leak will be there, and formation of a fibrin cuff. So this fibrin cuff is important because it will limit oxygen flow to the tissue. So tissue hypoxia will develop, and this tissue hypoxia is very important factor for the development of venous ulcer. Okay, and associated inflammation will be there because there is leakage of white cells also along with RBCs. So the sequelae will be, the outcome will be, there will be clinical sequelae which consist of edema. Okay, then lipodermatosclerosis, what is that, we will discuss, and ulceration. So in this manner, first edema will develop, then lipodermatosclerosis will develop, then ulceration. So one point to remember is perforator veins transmit high pressure from the deep system directly to the superficial skin surface. Remember, perforator veins transmit high pressure from the deep venous system directly to the superficial skin surface. One point to remember. Okay. Now coming to the clinical features. So the references are already there here. Okay, these are not from net. Okay, some software is utilized to make these slides, but basically these are from standard books. So it is a continuum. So CEAP classification is mainly used. What is CEAP? C for clinical features, E for etiology, A for anatomy, P for anatomy, P for pathology. Okay, so mainly we use here the clinical feature part of this CEAP classification. Okay, so class 0 is no signs of venous disease. Class 1 is telangiectasia, meaning veins which are visible but less than 1 mm diameter, or reticular veins, the diameter is 1 to 3 mm. So name differs based upon diameter. So you can see here a patient with this telangiectasia or reticular veins. So remember, having just telangiectasia or reticular veins does not say you that the patient is having chronic venous insufficiency. No, it is the initial stage. Okay. Then class 2 is development of varicose veins. What are these? Subcutaneous dilated more than or equal to 3 mm veins in the standing position. So these are varicose veins. So this image which you are seeing here, this is varicose veins. Again, here you can see this point. This is a telangiectasia or reticular vein. So this is a varicose vein. On standing, this will become more prominent. Okay. Why these are visible? Because there is valvular failure, and now when the patient walks on standing, so instead of going forwards upwards to the heart, now the blood is pumped back towards the superficial veins, pumped back towards the that's why these varicose veins will develop. So this is the first stage of where you see a clinical sign. So that is edema, and this is a pitting edema, and it is reversible initially. Okay, then C4, class 4. So it has C4 and C4b. Okay, C4 is just pigmentation, and state is dermatitis, and C4b will is lipodermatosclerosis. Class 5 skin changes along with healed ulceration. Class 6 is skin changes with active ulceration. So C4 to C6 is the important, but the initial thing which is there is class 3, where you see just edema. So class 4 you will have state is dermatitis or lipodermatosclerosis. Class 5 with healed ulcer. Class 6 is active ulceration. So remember, this disease is a continuum. Without intervention, the patient progresses down the scale. Okay, moving forwards. So same thing. So this is our classification actually. So which is based on clinical features only. So what are the symptoms? Primary symptoms: patient will feel heaviness or fullness in the legs, aching or bursting pain, painful muscle cramps, specifically at night, pruritus or itching, which is associated with skin changes, meaning state is dermatitis. Restless leg syndrome symptoms patient will have. Okay, so these are the primary symptoms. So timing and provocation. So what thing worsens this? So morning the patient will have less symptoms. So towards evening the patient will have more symptoms. Prolonged standing and sitting will worsen the symptom, and heat will also worsen the symptom because it causes venodilation. Okay. What improves the symptoms? Elevation of the legs and walking, which activates. So elevation will cause flow of the blood from limbs to the heart, and walking will activate the muscle pump. So that's how it improves. So this is very important point. But one point to remember is, one pitfall is venous claudication. This is not venous claudication. So remember, the pain of CVI is not a pain of venous claudication. What is that venous claudication? Pain that occurs while walking is not venous claudication. It will occur when the patient is sitting, standing for a long time, and towards evening it will be more, and in morning it will be less. So while walking, if the pain is there, so then there can be associated deep venous thrombosis, unlike typical venous pain which improves with walking. Okay, yes, of course. See, chronic venous insufficiency will improve with walking. Why? The peripheral pump will be activated. And if it is present that the patient is complaining of pain while walking, that it may indicate severe deep vein occlusion or obstruction. Okay, at that time you should consider two things. One is DVT, and second one is intermittent claudication due to peripheral artery disease. If this is there while walking, if the patient has the pain. Okay, now let's move forwards. So now that was about symptoms which the patient says, signs and examination which the physician will see. So what are the early signs? You can divide into early signs. Okay, early signs, chronic signs, advanced signs. Early signs, the earliest sign is C3. Okay, pitting edema. So usually it will be asymmetric and it resolves overnight. That is important point. Okay, then corona phlebitica. So it is an ankle flare. And what is the meaning of this? If this is present, this is nothing but a what do you call reticular telangiectatic veins which are present at the ankle. So this signifies there is very increased venous hypertension. Venous hypertension is very high. So presence of this corona phlebitica, which is a finding at the knee point, suggests that the venous hypertension is high. Venous blood pressure is high. Okay. So note is bilateral symmetric edema suggests systemic cause. For example, heart failure, medications, or CKD, or liver disease. So bilaterally, if you see, then it can be chronic venous insufficiency, but more commonly it will be unilaterally. Okay, this chronic venous insufficiency. Bilaterally, you should think of means your differential diagnosis should include along with this your differential diagnosis should include heart failure and kidney disease and liver disease and medications. All these things you should include. Okay, And chronic signs are the development of skin changes. So this is nothing but C4. Okay, C4. So there'll be hemosiderin deposit. What is the hemosiderin? So there is this hemosiderin is released from the RBCs, which have been leaked from the capillaries. So they will be broken down and they will release a pigment known as hemosiderin, and this hemosiderin staining will cause rusty brown discoloration. Rusty brown, as you can see, it is rusty brown in color, and it is associated with statitis dermatitis. Okay, rusty brown coloration. Okay, here you can see properly. Here, this erythema is because of dermatitis. Okay, erythema is because of dermatitis, and here and all you can see rusty brown, meaning towards blackish side. Some blackish discoloration will be there. This is because of extravasation. Okay, and presence of this skin changes and presence of statitis dermatitis. There will be erythema, there will be scaling, there will be eczema, itching will be there. So these two things, presence of this discoloration and statitis dermatitis, this points that the problem has become chronic now. What are the advanced signs? So advanced signs are lipodermatosclerosis. What is that? Panniculitis of inflammation of fat. Okay, fibrosing panniculitis. So the fat which is present in the deep fascia will get inflamed, and there will be fibrosis in the deep fascia. So that will cause a particular appearance of the leg. So which will be there in the slides coming. So leg will be normally like this. Okay, sorry, it will be like this. This is the leg. So this leg will become like this, like this. What that means? And this will be the foot. Okay, this will be the foot. What that means? Just below, above the ankle, there will be constriction of the lower leg due to fibrosis. Due to fibrosis. So this will resemble like a inverted champagne bottle. So champagne bottle, if you see, it will be like this, no? It will be like this. So if you just invert this is known as inverted champagne bottle appearance. So the hallmark of that is the constriction of the leg just above the ankle. That signifies lipodermatosclerosis, champagne bottle leg appearance. And atrophic blanch. What is this atrophic blanch? So these two things, lipodermatosclerosis and atrophic blanch. White atrophy, avascular patches. So small white scars you will see at the ankle. See the edema of the leg. The leg is very much edematous. So these are small white scars actually. Okay. So these are atrophy blanche. So discoloration and statitis dermatitis are chronic. Lipodermatosclerosis and atrophy blanche are advanced disease changes. Okay. So what are the differential diagnosis then, and how to triage the patient? So you should differentiate it from acute deep venous thrombosis, differentiate it from peripheral arterial disease of, for example, mainly from deep venous thrombosis you should differentiate, and lymphedema mainly. But if there is ulcer, then you should differentiate from arterial ulcer. So first we will see how you will differentiate it from acute deep venous thrombosis. So chronic venous insufficiency, it is chronic, insidious in nature, onset, improves with elevation of legs, whereas DVT is acute onset, unilateral pain and swelling will be there, urgent ultrasound will be required, and the patient will have venous claudication, whereas venous claudication will be absent in chronic venous insufficiency. And you can see some skin signs also there, but along with skin signs you can also have DVT. Just remember there will be venous claudication here in DVT. It is acute onset, you will have unilateral pain and swelling. This will improve with elevation, but this will not improve with elevation, and there will be venous claudication. Lymphedema, how you will differentiate? So obstruction of lymphatic drainage. So there will be dorsal hump of foot. So remember this point. So the main swelling and all things which appear in chronic insufficiency is mainly concentrated on the calf region. Okay, foot is not that involved in this. So if there is a dorsal hump like this, dorsal hump of foot, and square toes, the square toes meaning the toes are very much big, square toes. Okay, and stemmer signs is present. What is stemmer signs? If you pinch the skin of the dorsum of the foot, it is not pinchable. So that is stemmer sign. Non-pitting in late stages, and this edema, this kind of thing will be non-pitting. So that's how you differentiate from lymphedema. So differentiate from deep venous thrombosis and lymphedema. Now if there is ulcer, how you differentiate venous ulcer from arterial ulcer? So venous ulcer will present at the medial malleolus. Gator's area, it is called as Gator's area. Okay. Arterial ulcer will occur distal toes and occurs at pressure points. Remember this point. What is the appearance? It is shallow, wet ulcer, irregular borders will be there. Whereas arterial ulcer will be deep, punched out, okay, border, and it will be dry and pale. Okay. Pain here is relieved by elevation, whereas pain is worsened by elevation in arterial ulcer. And one examination point here is the pulses. Okay. Pulses will be weak here, but pulses may be normally present in a venous ulcer. So pulse examination is important in arterial ulcer. One safety warning is never apply compression bandages which you use for the treatment of this chronic venous insufficiency without checking the pulses or ankle brachial index. Ankle brachial index, don't apply the compression bandage. Compression bandages should be applied only after checking the pulses and particularly ABI. Okay. Moving forwards. How do you diagnose? So this is important. Okay. Step 1, you will take a history and physical examination. Assess the pretest probability. Assess pretest probability. And risk factors you see. Risk factors you should keep in mind. Age more than 40 years. Obesity. History of deep venous thrombosis. History of pregnancy. And one more thing is family history is also important here. So family history, like, so they will have a family history is also an important thing here. Okay. So age more than 40 years, obese patient, and pregnant lady, history of deep venous thrombosis. So all these are risk factors for this. Step 2 is you should rule out deep venous thrombosis. If acute symptoms are present, urgent ultrasound is needed to rule out deep venous thrombosis. So you should rule out deep venous thrombosis. Step 3 is confirm the chronic venous insufficiency by duplex ultrasonography. Confirm the reflex actually. What is reflex? So maps, this will show that the walls are incompetent and there is retrograde flow. How much? For more than 0.5 seconds. Remember this point. The retrograde flow should be for more than 0.5 seconds duration. Step 4 is, now you have confirmed that there is CVI, chronic venous insufficiency in this patient. Now you assess the severity. Assess the severity by using the CEAP classification. Remember, assess the severity based upon CEAP classification. Villalta scale is a scale which is used for CVI after post-thrombotic syndrome. If the score is more than 15 or equal to 15, meaning Villalta scale is, if the Villalta score is more than or equal to 15, then that is considered as severe in case of CVI after post-thrombotic syndrome, after DVT. Ankle brachial index you should do, that is mandatory to rule out any arterial disease. Now, if you get the value of ankle brachial index as less than 0.9, you should pay caution when you are applying this compression bandages. And if it is less than 0.6 or 0.5, then it is a contraindication for applying compression bandages. You should not apply. That this indicates severe peripheral artery disease. Okay. So for CVI, it is CEAP. For post DVT, it is Villalta scale. And ankle brachial index to rule out associated peripheral arterial disease in these patients. So this is the stepwise manner diagnostic approach moving forwards. What is the management strategy now? So this is the basic management strategy. You can think it as a pyramid. So this is the baseline level which every patient should be set to do. So while the patient should be instructed to raise the legs elevation, how by above the heart. How he can do that? By keeping the pillows like this, you are saying. Okay. So the elevation should be above the heart for more than half an hour, at least 3 times a day. And counsel the patient to have activity, walking, cycling, to activate the peripheral pump, and reduce the weight if the patient is obese, if the BMI is more than 22. So these are the lifestyle changes which is the baseline: elevation and exercise and weight reduction. Okay. Then comes the second tier, level 2, that is compression therapy. So this may be enough at C3 stage, but at C4 stage you may require, or at C3 stage also you will have this compression therapy. What should be the grading, we will learn in the coming slides. So level 2 is the compression therapy. This is the core intervention. Why? The main culprit in CVI is the venous hypertension. So if you use compression therapy, so that venous hypertension will be reduced, because that will help, that will decrease the reflux of the blood in the veins, And this is the only method that slows the disease progression. This is the only method that slows the disease progression. Level 3 is you can use some drugs as adjuncts only. They are not a replacement for compression therapy. They provide just symptomatic relief and they do not halt the progression of the disease. So the main therapy is the compression therapy. These can be used as adjuncts. Level 4 is when the disease becomes resistant for all these things, then you can plan for level 4. So if the patient has some venous ulcer which is not healing for more than 3 months, then you can plan for this surgical procedures or endovascular procedures. Okay. So lifestyle compression therapy we should keep in mind, then pharmacotherapy, then interventions. Moving forwards. So pharmacotherapy, what he will give. So these medications improve the quality of life but do not cure the disease. So we know active drugs, flavonoids like diosmin, hesperidin, rutoside. So these improve the venous tone actually and reduce the capillary permeability. So that means that yes, you can reduce the edema and you can reduce the dermatitis and skin discoloration. All these things will be controlled if you use this. Okay, improve the venous tone, reduce the capillary permeability, help with edema and subjective symptoms. Saponins, example acin, horse chestnut. This has the best evidence for reducing the edema and inflammation. Others include pentoxifylline, aspirin, calcium dobicelate, ulcer healing support, or anti-inflammatory prevention. So these are anti-inflammatory. So diosmin, hesperidin, and calcium dobicelate are very much commonly used. I also use this calcium dobicelate very much in this varicose veins patient. But diosmin and hesperidin are the number one. So you should focus on diosmin and hesperidin more than this calcium dobicelate, which is commonly used. So diosmin and hesperidin, and rutoside also. Rutoside actually it is given a patient who has swelling. Okay, diuretics have no role like furosemide. They have limited role only for heart failure volume or volume overload, not effective in venous reflex edema. Okay, so remember diosmin, hesperidin, and calcium dobicelate. Okay, moving forwards. Compression therapy is important thing we should discuss. So what pressure grades you should apply? So 20 to 30 mm Hg pressure grades for mild CVI, small varicose veins prophylaxis. For prophylaxis, you can use this one. So this is up to C3, I think. Okay, C1 to C2. 30 to 40 mm Hg for moderate or severe disease for edema control. Okay, so this is from C3 to, you can take it as C5, and 40 mm Hg multi-layer, meaning at the ankle side the pressure is different, and if you move towards upside the pressure will be lowered, like that, multi-layer. So this is in C6 disease, venous ulcer healing. Okay, so that's how the pressure grade should be applied. 20 to 30 mm Hg C1 and C2, 30 to 40 mm Hg grade from C3 to C5, 30 to 40, and 40 mm Hg in venous ulcer patients. That should be multi-layered. You should apply upon awakening before edema accumulates, and graduated pressure should be there. Main meaning it should be maximal at the ankle and decreasing proximally. Okay, that's how you should apply the pressure. Now, what are the contraindications for this compression therapy? So absolute contraindications, relative contra. Absolute less than 0.6 ABI is severe, so you should not apply. Cellulitis, if it is there, should not apply. Severe uncompensated heart failure is associated. If it is there, then you should not apply. Relative contraindication is ABI between 0.6 to 0.9. So use lower pressure, that is 17 to 25 mmHg pressure gradient. Compression bandages. Okay, how you should apply, when you should apply, everything is there. Okay, before edema accumulates you should apply in not in the night, in the morning. Okay, moving forwards. Now how you will manage ulcers? So wound care principles. Moist healing should be there, meaning the environment should be moist. Sorry. So hydrocolloids or foams you should use more than dry dressings. Okay, the environment should be moist. Annabut is nothing but zinc oxide impregnated compression bandage. That is Annabut. This stand of care. Okay, then debridgement, removal of necrotic tissue is essential. And if there is infection associated cellulitis, then only systemic antibiotics should be used. Avoid topical antibiotics. Okay, so moist healing. Annabut is nothing but zinc oxide impregnated compression bandage. Debridgement, and if there is infection, systemic antibiotics should be used. Visual progression. So you can see this is an active ulcer, and you can see this is a scab and shallow wet ulcer with irregular edges, not punched out, and it is on the medial aspect. Okay, shallow medial malleolus granulation tissue is there. So healed ulcer. So this is the goal of therapy. Same patient, you can see healed ulcer. Okay. So the thing is, you think, well, how you will apply compression bandage when there is ulcer? So you should firstly dress the ulcer. You dress the ulcer, then you apply the compression bandage. Okay, that's how you should apply the compression bandage. Compression bandage is without compression bandage you will not do. You can't make the ulcer to heal. Okay. Now some special situations. There is something known as pelvic congestion syndrome. What is the definition of that? Chronic pelvic pain associated with pelvic venous reflex or pelvic varicosities. Pelvic vein reflex varicosities. What is the mechanism? Venous insufficiency of ovarian and internal iliac veins. So this you see in multiparous women, meaning the women who have undergone means who have developed more number of deliveries, normal deliveries. So those multiparous women, they will develop this pelvic congestion syndrome. They will have varicosities on the vulva and thighs. Vulva and thighs, they will develop varicosities. Okay. Diagnosis is complex and it requires vascular workup. So these are the surgical interventions. Okay. When it is indicated, if the ulcers are refractory for more than 3 months, then, or if the symptoms are severe, not controlled by this the conservative measures, or if there is bleeding from the bleeding, if there is bleeding, then also you should require. So these are the three indications: refractory ulcers, ulcer more than 3 months, severe symptoms, and if there is bleeding. So what are the methods? Ablation by laser or radio frequency. Oh, so where you use incompetent saphenous veins. Sclerotherapy. So you inject a chemical and you will fibrose the vein. Chemical injection for this is for small veins. You will apply like telangiectasia, smaller veins. You use sclerotherapy. For saphenous veins, you use ablation. Stripping. This was older technique. Ligate and remove the vein. Okay, which is abnormal. But this technique has a high chance of reoccurrence. Then next is skin grafting for refractory ulcers. High recurrence if reflex not corrected. Okay. So this is a summary of the whole topic. You can remember. So mechanism is pump failure. Pump failure was a valve incompetence and muscle pump. Visual examination. The medial malleus is the venous corner. Brown skin is because of hemosiderin, which is released from RBCs. Clinical distinction: if it hurts to elevate, think that it is arterial ulcer. If it helps to elevate, then think that this is venous ulcer. And you should have differentiate from deep VT. How? DVT pain will aggravate with walking, whereas venous CVI pain will not aggravate with walking. Management is compression is the king. Okay. Drugs and surgery fail without compliance to compression. Okay. Remember the Villalta scale for grading post-thrombotic syndrome. What is this then treatment for post-thrombotic syndrome CVI? So prevention, it is already discussed in the topic of DVT. So compression bandage help in compression bandages. Proper managed. For first of all, when there was DVT, that should have been properly managed. But if that was not managed appropriately, then in symptomatic patients, these compression bandages or stockings can help. Okay. That's all about our CVI. Thank you. These are the references.